Okay, so this session we're about to start, and the panel discussion is on comprehensive screening ready for implementation, ? We have a wonderful panel with a very diverse background, ranging from academia to actuarial to industry to guideline organizations to Europeans. So it's a really terrific panel. I'm very eager to hear this conversation. But first, can each of the panelists introduce themselves, starting with you, Sam, and what your background is?
Thank you. My name is Sam Aguayo. I'm a pulmonologist and the medical director for the I-ELCAP program at the Phoenix VA Hospital in Phoenix, Arizona.
Yep. My name is Kazerooni. I'm a cardiothoracic radiologist. I head up our lung cancer screening and IPN program, and we were a site for an LST.
I'm Bob Lee. I'm a medical oncologist and serve as Senior Vice President, Global Head of Medical Affairs at AstraZeneca.
Bruce Pyenson, I'm a healthcare actuary, and I've touched just about everything in healthcare that moves over the last 30 years.
Can't beat that. Vliegenthart, I'm a radiologist from the Netherlands. I'm professor of cardiothoracic imaging, been involved in the Nelson trial since the start, and I led a population imaging study focusing on comprehensive screening.
Good morning. I'm Neil Rofsky. I'm the chair of the Department of Radiology here at Mount Sinai and historically a prostate cancer researcher.
Wonderful. And let's just introduce the co-moderator.
I'm here for the color commentary. My name is Jim Mulshine. I'm a thoracic medical oncologist, and I'm looking forward to a very stimulating session.
Okay, great. Well, we're going to be talking about implementation and how are we ready, where we're at, what's it going to take to make all of this happen. And I am chastened a bit by my experience with lung cancer screening, because I think I mentioned this yesterday. I thought after the initial I-ELCAP publication and a couple of more publications that it would just take off. Everybody would be doing lung cancer screening. And to my great surprise, thank you, Marianne, that didn't happen. And it really took something like the NLST, a massive randomized control trial, to really make screening start to happen. And even then, it required another trial, the Dutch-Belgian trial, to really start convincing the world that it was so the power of trials and just convincing people. As I said yesterday, I personally was not convinced that we needed that extra information, but I am convinced in terms of what it provided, but I am convinced completely that the trial itself was very powerful in motivating the world to say we need to do lung cancer screening. This was a question we asked at the last meeting in Bangkok. Over the next 5 years, do you envision low-dose CT screening for lung cancer, primarily keeping its focus on lung cancer, slowly integrating additional screening elements, rapidly expanding into a comprehensive multi-illness screening program, or becoming totally bogged down due to cost, litigation, and technical challenges? And you can see the answer. The overall feeling was slowly integrating additional screening elements. I have, as I like to use the word, I dream of the idea that we can rapidly expand into comprehensive multi-illness screening. But I've had that recurring dream for over 20 years now, by the way. So maybe we're at that point. I showed the slide yesterday that maybe we're at that inflection point. I really hope so. Okay, so let's start with some questions for the panelists. Do you think these technologies are now currently being implemented in a meaningful way in the context of lung cancer screening? And which ones do you think are really ready to be pushed forward, like coronary artery scoring, emphysema scoring, some of the other ones you saw in the prior session? So please start. Sam, why don't you start?
Thank you, David. So I will think that in the VA system, we are going to rapidly expand into comprehensive screening. The reason is that the findings that the technology is providing is it triggers actionable information. It triggers more communication between the primary care providers and the specialty care providers. And importantly, the VA system is already managing lawsuits for patients that meet current criteria for lung cancer screening and have actionable information from the imaging systems and have not received appropriate management for that actionable information. So I know that the VA is different than many other communities or even healthcare systems, but the liability of acquiring information that is predictive, both long-term but also urgently, is what's forcing the VA administrators to be more proactive on how to manage lung cancer screening. I'm going to show some of that data later this afternoon.
Lawyers got to you guys, huh?
So it's an interesting question from there's a scientific lens on it. There's a public health lens on it. There's a litigation lens on it. There are many different kind of pressures towards this question. And I think like you, as you mentioned with how long it took to get lung cancer screening approved in the US after there was I-ELCAP study and a big NLST, and then get to changing the criteria, is that the threshold by which to trigger public health screening tests is very high, and it's randomized controlled trials. We have randomized control for lung cancer screening. We have USPSTF recommendations, and our American Academy of Family Physicians, their own criteria for guideline development require 2 randomized controlled trials. So when you saw the Nelson trial published, the American Academy of Family Physicians then started to recommend lung cancer screening. So we have these structures that are in place about making recommendations. I'm a big believer in reporting all the things that we're talking about in reporting our lung cancer screening CTs and all of our chest CTs, fatty liver, bone mineral density, COPD emphysema, interstitial lung abnormalities, because I think there's information in there that at an individual patient level can be very helpful. And then I think we have a duty and a responsibility to provide that information. I think where it starts to break down is for many of those things, there's no discrete actionable pathway on which to do something with. Now, coronary calcium, I think we have discrete actionable pathways on what to do with that information. A failure to do that could be harm. Those are important, incidental, but not unexpected findings. But for other findings like mild emphysema, there is no scientific literature to support what to do next. In an asymptomatic person who has normal PFTs, what do you do? So I think for some of these things, it's asking and having to do the research to understand what do you do, because we can see things, but we may not know what they mean. I know if I find an incidental lung disease, incidental lung abnormality, there's many studies now on the rate of progression and what you need to do next so that we have recommendations. We don't have that for early COPD. So taking things to the next pathway about what do I do, what's actionable, how do we help primary care execute, I think is critically important for readiness.
Thank you. And I might just chime in, also believe that rapid expansion, the time is now. And I give a lot of credit for the pioneers, David, Claudia, for envisioning this some 20 plus years ago, but the technology just wasn't right. And the timing around the world is not there yet at the time. But now, post-COVID, the world is more interconnected with technology, democratization, Zoom, Teams, social media. There's all this connection, and the advent of agentic AI is allowing us to really have scale of impact. Now, I joined AstraZeneca just 10 months ago from an academia background. I was practicing just down the street at Memorial Sloan Kettering Cancer Center as a medical oncologist. And I joined because of that potential for scalable impact, that rapid expansion, and because of public-private partnership, that academia and industry can work together. Industry is also evolving rapidly from the days of blockbuster pharma to now AstraZeneca investing heavily in screening. You know, one would think, why would a drug company invest in cancer screening? Patients will be cured and there will be no drugs to take if it's about cancer. But in fact, it's a strategic direction for the company, because if you invest in screening and if you have diagnosis at a curable state of disease, your medicines are going to make tremendously more impact than in the metastatic palliative setting. And that's why all of our R&D strategies are going into early stage cancers, whether with EGFR mutant lung cancers, with bladder cancers, with gastric cancers. We're going very early and not content with just months of survival benefit in the metastatic setting. But to really succeed, you've got to have the ecosystem. You've got to have the fertile soil for patients to be diagnosed at that early stage. And I just, since joining the company 10 months ago, I've been inspired by the incredible pace, energy, passion at the company. We heard earlier from Iskra and Claudia and others that about some of the innovative screening programs in the developing world. We heard about El Salvador, and I would just maybe give another example from Colombia in the same Latin American region. We have Colombia, a country of 40+ million people, but their lung cancer is often diagnosed so late that you know, in around the average in North America, metastatic disease diagnosis in lung cancer is about 30–40%, maybe closer to 40 than 30, but varies by region. But in Colombia, that number is 67% or almost 70%. So most people are diagnosed late because the early diseases are ignored and undiagnosed, untreated. So we partner with the Ministry of Health and with academia, community practices, and rolled out a project called Consultorio Amazonas. And this is in partnership with a biotech company called Cure AI. It starts with the Q. We're just a partner. It's not a company we're trying to promote, but this is a real partner that's developing AI-guided chest X-ray, really developing algorithms from chest X-ray findings to early cancer detection in lung cancer. And through that program, you know, you have routine chest X-rays done for all kinds of reasons, and you have it in store. As long as you digitize it, you can scale the findings very quickly. So in a pilot study, we looked at more than 130,000 patients with just routine chest X-rays. And we were and AI just does it with pace. You know, you can do it in a few minutes probably. And you can do that, and we can find just 40+ patients with early stage lung cancer that otherwise would have been left completely untreated until they get metastatic disease and die from the disease. And we were able to rapidly partner with community clinics and intervene on those patients and save their lives in time. So that's a pilot study. Now we are reaching communities of 3.5 million people, and the aim for next year is 6.7 million people. And by partnership, you know, it's a country of 40 million, you know, you can really scale to reach the masses, and then imagine the kind of lives that you can save just through AI automation and partnership, public-private partnership, multi-stakeholder partnership. So we all have a role to play, and I'm really thrilled to be here with all the esteemed specialists coming from really diverse backgrounds. Thank you.
David, I very much agree with your statement about randomized controlled trials, and would point out that there's an awful lot that we do in healthcare that has never been validated by randomized controlled trial. But that said, what I think is missing from the comprehensive screening is a public health pro forma. So we don't have even good estimates or sketch estimates of the impact on a population of the various elements that are being proposed to be screened. And any, you know, traditionally, any kind of business starts with a pro forma. We don't have perfect data, but we have good enough data to come up with estimates of what the different elements of the flower of comprehensive screening, what each of them might do to a particular population. Take the US population or take some other population. I think that is going to be a real challenge without that, because why should investors or why should governments support something without that, based on what seems to be a daisy chain of wishful thinking by various advocates. So to give an example of how much that's missing from today's dialogue, just in the case of lung cancer, there's the traditional CDC estimate of lung cancer deaths annually in the US. People know what it is? 120,000 or something like that. What's the global burden of disease estimate for the number of deaths in the US? Global burden of disease, Gates Foundation. It's about 190,000. It's about, 50% higher, based on a methodology that reclassifies trash codes, like someone dies of inhalation pneumonia, gets reclassified into lung cancer if they had lung cancer. So we have this mystery data out there, and nobody's really put it together. So even for something as basic as lung cancer, of course, the 120,000 is the figure that the American Cancer Society uses from the CDC, because they've always used it. So anyway, that pro forma for the population health impact, I think, is really missing, and it needs to be put together.
So there's two things. So I've got my personal opinion, and I'll gladly discuss it at a later point. But what I'd like to do is address this from a Dutch governmental perspective, because I'm the only person from Europe in here. So there are very strict standards for allowing a new screening to be entered into the public system. I think that is in the Netherlands, but also in many European countries. And it has to be based on cost effectiveness analysis of randomized controlled trials that show the benefits of the screening and also compare it to the disadvantages. And so for lung cancer screening, of course, we have that information, we have that evidence, but for many of the comprehensive screening additions, we don't have that. So for coronary calcium, of course, we have a lot of longitudinal data. It's an extremely strong predictive factor for cardiovascular disease, even on a non-gated chest CT. But for example, for osteoporosis or indeed mild emphysema, we just don't have that data yet. It's coming. We do have a trial now ongoing in the Netherlands that's focused on screening cardiovascular disease. It's a Robinska trial, but we don't have the outcomes yet. And so the question is, will a Dutch government or any European government allow all those extra screening parameters to be entered into the same screening without having the evidence that it actually improves morbidity and mortality? I think for coronary calcium, because the observational data is so strong, I think we cannot ignore that, and we'll make a strong point to include that directly when we start lung cancer screening. But for the others, I do think we need a trial, unfortunately.
Well, as the chair who manages a lot of people and budgets, I'll give you a different perspective, and that is, what is it that this comprehensive scanning can do? Okay, what is it that is actionable? What are the logistics behind it? And is it reimbursable? So if we break down comprehensive scanning into different parts of comprehensive scanning are in different stages. So readiness, right? Or what is the activity? There's a lot to do in research. And there is some opportunity for clinical. So the two areas that I think of in clinical are going to be coronary artery calcification and osteoporosis. And I'm going to focus on osteoporosis because it's an area of interest of mine. There's a clinical gap. Only 20% of patients get a DEXA. DEXA is approved. We know that there's substantial morbidity and mortality related to undertreated osteoporosis. We know that the mortality is significantly high in the elderly when they fall and break their hip. We should be able to make a determination. Well, guess what? We have the tool right now. Several people, including Mort and company, have done the work to show that the BMD on a CT scan has a correlation with DEXA, and you can get a T-score. So it's ready. And I don't think we need a large clinical trial. I think we got to report this out and figure out, start small and go big. Where is the patient population? One place that we're going to focus on at Mount Sinai are oncology patients, because these are patients who need serial CT scans. They are underdiagnosed with osteoporosis and they are living longer. So they definitely need this. Now, the logistics, what happens when you work this in? Is this where you hire a zillion navigators, or can we actually leverage agentic AI? That's the key. I don't think it'll make it if we need lots of people to navigate this, because think of all the indications in addition to your lung cancer screening. You saw the whole spectrum. It's a lot of people. Agentic AI is the solution for that. And then I think the question is if we have these tools, are they reimbursable? And how do we prove they're reimbursable? What's FDA approved? Do we knock this off into small little bits? Do we go into a comprehensive approval? What's needed for that approval in order so that we have some kind of reimbursement for all the energy, effort, and logistics that we need? So I'm optimistic, and I think starting small and nipping it off in defined areas is the way to go. And we're very optimistic about agentic AI as the tool to help us be successful.
Well, thank you all for those comments. And so to kind of follow up, two observations. One is the cardiologists, the preventive cardiologists have done a great job in terms of developing appropriate interventions in their system. And we know that they have, for instance, demonstrated that exercise is a drug, and that it's in randomized trial at least as efficacious as statins, and there's various other studies that have been done looking at other dimensions of this. Chronic COPD, we've known for decades, the leading cause of death in that setting is cardiovascular. And there's no reason to believe that cardiovascular disease in screening populations behaves differently than cardiovascular disease in the rest of the population. So the business about the data being so compelling in cardiology, the perspective that osteoporosis already has so much background information that we have a mandate to action has to be developed, because the difference between all the other things that U.S. Preventive Services Task Force is weighed in on and stuff like that. And by the way, in their last review of COPD, one of their observations was that there's no research whatsoever about preventive exercise measures in chronic lung disease. None, zero, no studies to evaluate. So that's remarkable. But the other thing that's crazy is that the data already is being acquired and being reimbursed under the NCD for lung cancer screening, for cardiovascular, for bone. And in a situation where they have a study, and Sam kind of touched on this, and the information is available, and Ella's going to tell her patients about it. In Netherlands, we don't mention it. What do you do when they have asymptomatic but advanced emphysema or advanced coronary calcium? We have no ethical standing to withhold that information. We are advocates for our patients. That doesn't mean we get to decide what we tell them. When there's medically objective information that is life impacting. So given the kind of new setting we have, where we can kind of reframe these things relative to public health interventions, given the available literature on cardiovascular disease and on osteoporosis, how does that affect your approach to your population over the next 5 years in terms of what you might engage in to advance this opportunity? Sam? Oh, no, please, you have to go.
I just want to jump in because I do have
Thanks,
to
Ian.
leave. So I'm going to stick with the osteoporosis. We're building into the entire logistics, into integration with the EMR to say somebody's come through. We want to ping and say, do you have a care gap? Have you had a DEXA? If the answer is no, we go ahead and we go with the CT and we apply the AI algorithm that is relevant. And we report that, and then we connect that back to an integrated approach to be sure that that individual gets the workup that they need. And if it requires bisphosphonates or an infusion, they will get the care. So it's an integrated approach. And I think it's very challenging to do it for the entire set of conditions. And that's why we're focused right now on the osteoporosis.
Can you leverage the cohort specifically already getting CT scan for lung cancer screening to kind of be a vanguard for your efforts?
We've already, we've gotten data. What we're doing now is we're looking at a cohort of patients, the oncology patients who are getting CTs anyway. So this is not, it's not limited to lung cancer. It can be any cancer. You have a renal cell carcinoma and you're doing serial follow-ups. We'll have that osteoporotic information. We'll have it integrated into the EMR. We'll connect them with care providers. It's that total integration that's missing. There's a lot of identification possibilities. Some of it's being identified, but the care integration has been woefully inadequate.
Okay, Ella wants to jump in.
Well, sometimes I think you have information that I think we all agree is useful and could impact patient health, not just population health, but individual patients' information is, I think of two things. We have a duty as physicians to do no harm. And when we see abnormalities that could be impactful, as a radiologist, I find it, I guess I should use the term unethical, to not report findings that are there on the CT scan. Now, others would argue with me and say, but you don't know what to do with some of those findings, so is reporting them unnecessary, creating unnecessary patient anxiety? Well, who am I to decide how a person is going to react to the information when I don't know the person that I'm producing a radiology report for? I'm providing information, but it does speak to the complex. The diagnostic process is complex. And as Neil outlined, even just one entity, osteoporosis, the pathway, the navigation, the closing the loop to make sure that it's done correctly and acted on is important. So I can provide I think from my standpoint as a practicing radiologist, I can provide the information in my report. And for certain things, I can put in a recommendation. When I see an unsuspected interstitial lung disease, I put in, pulmonary function tests and referral to pulmonary medicine. Some of the things I have actionable information, but for many of the things I don't have an action to recommend. So I'm producing content and I'm hoping that somebody will use that effectively if they know what to do in the right scenario for their patients. So that's a big gap that we have. We have content, we have information, but we don't necessarily have how you're going to use it. I think the other thing, so we as radiologists can try and push that information forward and create the content. But I think the other community is the patient community. When I talk in different settings about artificial intelligence, in a democratized world, as you described, anybody can get their CT scan data and drop it into tools that are available online. People can create tools based on publicly available databases and then throw their CT scans in it. So to think that we're going to somehow withhold this information from patients that is there in their CT scans in this era of AI and democratization and ability to use your own data, I mean, younger generation and some of us older generation who are maybe a little more IT sensitive will take our own information and put it into systems that the healthcare system doesn't. And then I guess the last leg I would say is the fact that we might have to rely on litigation to drive the practice of medicine, to me, is a bit frightening. I mean, if we think we know what the right thing is to do and we're holding this information from patients and giving it to them, That's like the last leg. Unfortunately, sometimes that's what it takes. So I think there are other levers, appealing to radiologists who practice to put information in the report that patients should be able to have, democratizing the ability to take your own data and put it into tools yourself if they're not being provided, and patients, the public, the consumers pushing us to do this.
Thank you, Neil. Rosemary, I've been a bit unfair. How about your personal perspective?
I'll get to that right now, Jim. So, in a screening, we screen presumed healthy individuals, but as we are talking about, these individuals we may find signs on a CT scan
Speaking to the mic.
that indicate an elevated risk for any non-communicable disease on the long term. And I think we need to think much more integrated into a healthy aging prevention center, basically, not in a hospital, because they're not patients. We try to prevent that they become patients, but we need an integration where healthy lifestyle is promoted, because I think that's better than medication, if it's possible. But where that starts to live and where everybody can get screened, because now we're talking about people who have a history of smoking. But if we're talking about all the different parameters that we're talking about, any of us have any kind of risk factors for any kind of these diseases. So that opens up a spectrum of possibilities for all of us to become much more involved in our own healthy aging. I think that would be great. If we could get there, we would have a huge difference in the entire society, I think.
Pretty exciting, huh?
I might just give an industry perspective here, because this comprehensive approach is very consistent with the World Health Assembly resolution passed in May this year on an integrated approach to lung health, both communicable and non-communicable diseases, tracking it together, making impact on patients early and together. So in AstraZeneca, we have invested in early cancer detection and screening initiatives. We have a One Lung Health program where we actually, when we do lung cancer screening, we catch COPD, emphysema, any radiological signs of asthma. We would intervene and to make sure those patients are not falling through the cracks, and vice versa as well. So I think that approach is now being part of our discussions with policymakers. And certainly that integrated approach to lung health is something that AstraZeneca has also played a significant role in policy shaping. So we're very proud of this morning's MOU agreement signing with I-ELCAP together through policy shaping, public-private partnership. We could make those sort of healthcare system-wide difference for scalable impact on patients. And finally, I just wanted to build upon Ella's great point earlier about the patient. Before I left practice just 10 months ago at MSK, my patients were already calling the office because they have seen the CT report and used their ChatGPT agent to scan the report, these 3-page reports, and completely come up with suggestions that your cancer is shrinking, Dr. Lee's treatment maybe is working okay, you probably don't need to switch doctors for now, but my patient was calling the office, just leaving a voicemail, a message with my office assistant just to check if Dr. Lee agrees with that assessment. And this is even before I had a chance to read the report. So this was last year. Very soon, it's going to be radiomics, it's going to be AI reading of the radiology scan when they have access to that. And it's going to be all kinds of diseases, not just the one that the prescriber had asked for. So I think this is unavoidable. And in many parts of the world, why developing countries are doing lung cancer screening at scale, it's because they do it fast, they do it cheap, and with technology democratization. So I think that's the future, and we have to actually I agree with Ellen, not let litigations and fear of legal implications get in the way of good patient care. We actually have to embrace this unprecedented moment in medical history to really make broad, scalable impact.
So given that we're going to have this more interactive kind of environment, which I think is very positive. I don't think it's inevitable. I think it's great. I think we should lean into it. What's the cost implications from your perspective, Bruce, as we move from treatment of advanced disease in a, palliative kind of setting many times to this more preventive world that Rosemarin just talked about and Dr. Lee just talked about?
Well, with the cancers, in particular lung cancer, the cost effectiveness studies that have been done are mostly using old data before the advent of cell and gene therapy. I believe that newer studies would show actual net savings from the stage shift because the cell and gene therapies are so expensive. And in the past, the cost differences of treatment by stage were not nearly as great as they are today. So the cost equation is changing, but to bring it back to a population basis, if we think about the population today that would get lung screening, in the US, it's what the eligibility may be 15 million lives, something like that.
With the new ACS guidelines, yes.
So something like 15 million. And just to really simplify, the total Medicare population in the US is just over 60 million lives. So we're talking about roughly a quarter of the older population. Really, it's certainly less than that because a bunch of people under 65 are eligible for lung screening. But the question is, until we can get to the point of really expanding the screening eligible population, of those quarter of the people, older people, what portion of the total heart attacks, the total COPD, emphysema, et cetera, are concentrated in the screening eligible population? So we're not screening everybody. So we need to think about the rest of the population that we're not screening and what's our impact on the total population by focusing in on this particular high-risk group. And I think the data to do that is there, but I haven't seen anybody quantify it that kind of way.
So to simplify, I think you're saying cost is not going to be the barrier here once you get it to scale. Sam, you had some comments.
Yeah, I don't think, I think the biggest challenge is process, like Rick Avila had in one of his slides. Screening is not the imaging, is the whole process. Who you're bringing to the image and what do you do with the results? And the process is what's preventing us from even already screening the majority of the people that are already eligible. We're still lagging behind. In Phoenix, we have screened 24% of the expected cohort. And at the pace we're going, this is in 7 years. At the pace we're going, it's going to be 15 more years before we screen current guidelines eligible people. The people that we are screening are not innocent. These are chronic smokers that have done damage to their body. And when we start this conversation, what we talk about is, let's find out, how much damage has been done already. And if we can prevent unnecessary death from lung cancer that hopefully we catch early enough. These are no signs or symptoms of lung cancer, but these are not healthy people. These are patients, many of them who still cannot quit smoking, who over half of them may have already COPD that has never been diagnosed just because they're not very symptomatic. And the vast majority of them have very high risk for cardiovascular death that has never been quantified or informed to the patient to act on that. So our program in Phoenix is already the 5th busiest clinic in the system for new patients, over 6,000 encounters a year. We are the 3rd busiest clinic in the medical center, and we have the highest mortality of any outpatient clinic program except for oncology and palliative care. For every age group that we are screening, our mortality, not from lung cancer, all-cause mortality is higher than US mortality for that age group. So that's why I think comprehensive screening, sharing of information, and intervening when you can, when there is something you can do about actionable information, I think it's going to expand much faster than we anticipate today. And again, I'll show you some of low-hanging fruit data this afternoon on things that are right in front of us. We can do something about it, but the sharing of the information, the process of acting on the data is really what's holding us back.
Okay, we're out of time. Any burning comments?
In the Netherlands, and I think most of Europe, healthcare is not a growth market. We have a zero net line. So that means that when we come with screening and we say, well, you're going to have an investment cost, the first question is where we're going to cut. And the ratio of healthcare personnel to people who need healthcare is going in the wrong direction. So that means that whatever way you look at it, you're going to have a huge investment to really go to comprehensive screening. And that needs a political system that goes beyond a perspective, a horizon of 4 years. They have to be long-term thinking. And that's
One of
tough.
the early findings from the Robinska trial, which has been published a couple of different times, is that a number of people are on statins that, according to their calcium results, do not need to be on statins. And if they get appropriate therapy, the cost savings in statins will pay for the entire trial.
Let's leave that for now, Jim. Let's leave that. So I just want to say, I think as physicians and as participants in this audience, I think everybody is fully on board with the idea of comprehensive screening. You heard Ella reporting earlier that she reads everything on the scan. I do too. And I have been very frustrated as to the fact that people are not really jumping on all of these things. People have osteoporosis, they're not doing anything about it. They have emphysema, they don't even know about it. And yet it's all in the reports. So how do we make all of this happen? Is it going to be that we need a big trial that shows some type of major healthcare benefit and every guideline organization says, that's it, we've got it? Is it what Neil was describing earlier, that we need a better sort of implementation pathway? Bruce will tell you he can probably get a lot of this information from, from financial records and from old Medicare forms and whatever. So I mean, there's a lot for us to think about. But anyway, I appreciate all of the input from the panel. This was a wonderful session. Jim?
Just in closing, just as sure as every session in I-ELCAP runs over time, comprehensive screening is going to come forward with lightning speed. The question is it going to come forward in a way that we can bring some rationality, some discipline, some learnings, some interaction in a positive way to let it come forward a little bit more efficiently, a little bit more thoughtfully, a little bit more equitably? That's our challenge, I think.
So Thank you very much to the panelists.